Everybody, thanks for joining me and welcome to the choosing between modifiers GA, GX, GY, and GZ webinar. We would like to help you avoid claims issues when possible, and making sure that you use the correct modifier is what helps you do this. I'm Tom Ryan with Provider Outreach and Education, and I'll be your presenter today. Today, I'm joined by Ashley from my team, who's going to help me with the questions in the chat. Her goal is to either answer the question directly in the chat or wait until I ask and then present the questions to me. She can do either one. So please make sure that if you put a question in the chat, you are seeing if she's answering it there. Okay? Really appreciate that. Um, Remember that there are a few disclaimers at the end of this presentation, and you may want to check out those disclaimers. One final thing, I did receive a few questions on hospice modifiers, which are GD and GW. That is not this session. That's the next session later today. It's in a couple of hours. So you might want to make sure you're registered to the right session. And if this isn't the session you want, consider going back to our website, to our live events page, and just register for that session. Submit those questions again, and I'll check it later and get everything up to date. So for this session, what are we looking at? Well, we want to review the use of these four modifiers to ensure you understand which one to use. We frequently receive questions about that and which sections and how to use them related to the Advanced Beneficiary Notice of Non-Coverage. So we do want to define the modifiers. We're going to explain when to use each one of the modifiers. And then we do have to look at the Advanced Beneficiary Notice of Non-Coverage, or ABN. The ABN is what CMS recently changed. That's why I sent you the PowerPoint. So the last section is where you're going to see those changes. Okay. I will tell you, based on this first question, I was asked by some people who are new to Medicare. I was asked to make sure I started at the beginning to make sure they understood the difference between not covered and not medically necessary, or non-covered and not medically necessary. There was also a few people who just commented that they were brand new, and I don't really know what you know and what you don't. So we're going to get into that a little bit here and now. And then we'll get into what you're actually here to talk about. So first, not covered. These are services not meeting the coverage categories in the Social Security Act. They will never be covered by Medicare because they are prohibited by law, or they are not part of the Medicare benefits. When we look at these services, they are not subject to the ABN or to certain modifiers that go with that. We'll explain the four modifiers in a few moments. Other things that you want to be aware of that are excluded in the law: if the patient has no obligation to pay, you are not required to bill Medicare. If the if the claim is paid by another federal entity, you are not required to bill Medicare. Personal comfort items, cosmetic procedures, and routine dental care. These all fall under that not covered. The one caveat happens is if the patient says, you got to bill Medicare, or I have secondary insurance, so therefore I need that denial, then you should bill Medicare. These are not covered services, or never covered services. We're going to talk more about that in just a little while. On the bottom of this slide, you'll see the Medicare Benefit Policy Manual, and it's going to reference Chapter 16. This is where I'm getting some of this information for you. Not medically necessary services. These are services that, based on the patient's diagnosis and documentation, are not covered today for that patient. So they could be covered, but they're not for Fred today, as one of our coworkers likes to say. So these are when you have to give an ABN to change the patient liability. So there's a big difference between not covered, never covered, excluded from Medicare coverage, and not medically necessary. So if it's not medically necessary, we will tell you that in our local coverage determinations. CMS will tell you that in their national coverage determinations or some of their manuals. Those are available on the CMS website. In this case, the provider who's doing the service must inform the patient that these are not medically necessary for their condition today, because of a frequency limitation, because it's still too experimental. So it's not medically necessary today for this patient, and that they may have a financial liability should Medicare determine that. That's what the advanced beneficiary notice of non-coverage does, and that's why we're going to talk about it in a little while. Well, also then drives one of these four modifiers. We're going to talk about that too. One particular question that I was asked deals with frequency. And they said, is frequency really not medically necessary? And the answer is no, that's not really what frequency falls into. On the other hand, frequency says if you have this once in a lifetime benefit, or you can have this every 24 months or every 12 months, that's based on something else. So that's why you do have to give an advanced beneficiary notice of non-coverage, ABN, which means you would appropriately use a certain modifier. We'll talk more about that. So that's what we're talking about when we talk about frequency. Your provider can argue as much as they want that it's medically necessary that often. However, due to Medicare restrictions, we can't pay it that often. And in some cases, we can only pay it once in a lifetime. Hopefully, all of that kind of makes sense, because if you don't understand that basic concepts, you're not going to get help from the modifier section, which is coming up next, and then the ABN section, which is our final section. So, okay. All right, let's move on. BNI, the Beneficiary Notice Initiative. This was something put in place by CMS to help your patients make an informed decision. The informed decision is when a service is not medically necessary or has a frequency limit. Therefore, Medicare will not pay for this service today. It also then says, hey, here's this optional use. You're going to tell them, but they already know. Well, how do they already know? The optional use is for never covered items, not covered items, or, however you want to say that. But basically, the law excluded them. Then it becomes an informational only. I was specifically asked, how does a patient know that? And the answer is CMS sends them a handbook annually. This handbook is called Medicare and You. You can look at the handbook and the basic information within the handbook every year and see what was sent out. It's on the Medicare.gov website. I just want to show that to you because I do want to make sure I address that question and that we are not leaving anyone kind of going, I don't get it. So let me just take you out to the website for a minute. First thing I want to point out is this is cms.gov. This is where most provider information is available. This is what we have to use too as your contractor. The patient website is medicare.gov, so it's two different websites. This one is written towards the patient at a different level. When you click on the term basics on the right side, and it's your, if you're coming from the right side of your screen, you'll see that it's 5 links over. It will open a new dropdown, and on the right side, the third item in the dropdown that is a link is Medicare and You Handbook. What's great about this is you can actually see by downloading the PDF what CMS told the patient. So then you can scroll through and find out what is covered, what is not covered. You can always use the Control F feature or the Edit Find feature. I'll just use ambulance just because. And what I'm going to do is make sure that, okay, it's going to say, hey, this is where we looked at ambulance. Well, what did they tell them? Well, here. Medicare covers ground ambulance. Here's where it is. Medicare pays emergency ambulance transports. Okay. If immediate, rapid. Okay. And so this is what they're actually telling them. Hopefully that helps you kind of understand what the patient is looking for. Now, on the other hand, there is a time when we do not know what's within here because the patient nor Medicare is saying it's non-covered today. What they're instead saying is it's not medically necessary for your condition today, or there's a frequency limitation on what is covered for your condition. And that brings us to the next slide, which is the ABN. Now, this is the form that was updated. There's a picture, a very nice picture on here of just the form itself, but we'll take a look at that in just a moment. We do want to point out that down in the lower left corner, you'll see a date of March 31st, 2029. That's the most current version, and that you do have a little bit of time to use that. We'll talk more about that in just a little bit. But what this form actually does is for outpatient services, It informs the patient that for some reason, whether it's not medically necessary, a frequent limitation, whether it's not a proven service, for some reason this service will be their responsibility should Medicare deny it. And we're going to talk about that in a little bit because that's going to be some different sections. So this is why the provider is required to fill this out in advance and then give it to the patient. And then when you go to bill Medicare, you must indicate why you filled it out and that it was properly executed. That is one of the modifiers. So we'll talk more about those modifiers coming up because that's exactly what they do. We're going to talk about the 4 modifiers and the proper way to use them. We'll get more into questions after we get through the sections, so I just want to make everyone aware that we're going to do that. So the first modifier is GA. This modifier indicates an ABN was provided for a not medically necessary service. Please note, this is not used for non-covered. This is only used for not medically necessary. When you read the CMS information, they will refer to this as a mandatory use of the ABN versus an optional use. And I'll talk about optional use and what that means next. But, so the ABN is given, it is properly executed and properly explained. That makes sense. It's got to be executed, which means it's got to be filled out correctly. And you've got to be able to tell the patient all the information that they may need to help understand it, or take a break and let them contact 1-800-Medicare before proceeding with the service. Because what you're telling them with this form is that they may be liable. They may have to pay for this service should Medicare not pay for it. So that's why you have to be able to do all those different components, okay? So you do have to give them the opportunity to ask questions about it. Now, Medicare does assume that you are using this form correctly, that it was completed properly, and that it was then stored as documentation properly. The assumption continues on unless requested by one of our medical review contractors or someone else looking at it for various reasons, fraud and abuse, a variety of other situations. So it's assumed that it's done right. If you append the modifier, GA, we assume that you did everything, everything's good. What this modifier does is it allows the claim to go through the entire processing system. It doesn't stop anything. This is considered an informational only modifier in that when you hit the final assignment of benefits, which occurs the very last item on a claim, and that assignment, or I'm sorry, not assignment of benefits, it assigns patient liability. That's what it does. So it goes all the way down and says, oh, this would be a contractual obligation. Oh, wait, it's got a modifier GA to indicate, yep, I've got all this stuff on file. So instead of being a contractual obligation, it changes that to a patient responsibility. It is one of the last steps in the processing of a claim before we issue a payment or no payment. In this case, it would be a denied service with a patient responsibility because you did tell us and you told the patient that. Okay, I want to make sure that that's clear to everyone. This does not affect any portion of claims processing until the end, which is the assignment of patient liability at the very, very end. Okay, let's move on down just one moment here. I was asked a question and I built this slide. Hopefully this will answer your question. One of the most common questions which we were asked is, you asked the patient to sign the form, but the patient said, I don't want to sign it, but I still want the service. Well, that's okay. That's called refusing to sign, and it can be a patient or it can be a representative. If it's a representative, we ask that you document that. You can put it in the narrative area. We'll get to that when we get to the form. So who refused to sign? So-and-so representative. The date. What happens next is a protection for you, and you'll see it on our side listed as a witness, and then with optional. I want to make it clear, CMS doesn't require the witness. We recommend the witness in case the patient calls this in through the appeals process to one of the legal systems. Because remember, the administrative law judge or level 3 appeal looks at it, and if it goes further, so does the level 5 appeal, which is done in a U.S. district court. So we want to make sure that we have someone to say yes or no to the patient. Okay. Yep, the patient was presented or who was presented and what happened. They don't need to necessarily know what's entirely on the form. What they're witnessing is the refusal to sign. And last, what's the service? Well, that always makes sense. What service are they up to? You should already have that documented. Otherwise, why are you giving them the form? If you do have a properly documented refusal, you still will use modifier GA. And that was one of the questions. Which modifier do I use? And the answer is GA. It's the same thing. It's called a properly executed advanced beneficiary notice of non-coverage. So just like if they sign it and date it, this is also then used. So hopefully I answered that well enough. If not, throw some more questions back into the chat. GX is next. Now GX says, I did the ABN, gave it out. I didn't complete the entire form because this service is never covered, not a part of the Medicare benefit package. That's okay. We used to call it blanks A through F, and I left that reference on here. I think it'll help you when you take a look at the actual form, and we'll talk about the differences a little bit coming up next. But it's basically the top part of the form through the chart, and the chart goes through the cost. So it's going to, do some different things. That's all you have to complete. We don't have to have the patient's signature. We don't have to have any of that. Well, why don't we? I showed you where the Medicare already told your patient this is never going to be covered because it's not part of the benefit package. It's called the Medicare and You Guidebook. That's why this isn't required to be. Now, if you notice, it also on the second bullet says, hey, this is an optional use. You don't have to append it. Well, okay, if I don't have to append it, why would I want to? It stops the claim from going through all of the audits and edits and says, okay, do you have your basic information right? Patient name, provider information, NPI for billing, basic information right. After that, it stops the medical necessity portion. It stops all of that. It simply says, hey, Medicare, deny the claim as patient responsibility. I already told the patient. Now, the next modifier is going to sound very similar, and I don't want you guys to get confused. GX means you did provide the ABN. GY means you did not, but the patient's already been told that's why you can use this one. This one simply says, I'm relying on the Medicare and You Guidebook, which you have the right to do, to tell the patient this is a never covered item or service. That's what GY indicates. This, again, is an auto deny, just like the GX. The GY works the same way. It does run through your basics. Do you have your patient information right? Do you have your provider information? Okay, auto deny. Don't do anything more with it. If you don't put the GX or the GY on there, yes, your claim will still deny, only it takes longer. Why does it do that? Because it still has to run through all of our audits and all of our edits to indicate that it's not a Medicare covered service versus you telling us it's not. Okay, so I want to make sure that's very clear. Next modifier, is a GZ modifier. This modifier is an informational only modifier. It is used when you did not provide an ABN for a not medically necessary service. So remember, I gave you an ABN. I told the patient it's going to be their responsibility because whatever the reason is, it's not covered for your condition today. It's outside the Medicare frequency parameters. It's not a proven and tested item. It's experimental use for this condition, whatever the situation is. Well, what happens if you don't tell them that? You simply didn't tell them. You forgot to give the ABN. Whoops. That's what the GZ represents. Now, a lot of people asked, do I need to use the GZ? And actually, we had quite a few questions come in. That's kind of a summary of them. And the answer is no. GZ literally does nothing. We still have to wrap it all the way through. We still have to go through every medical necessity edit. We still make a medical necessity determination. Unlike the GX and GY where we don't. You've already told us it's not covered. We're not looking at any of those edits and audits. What GZ will do is at the end when we say, oh, did you tell them or not? And remember, we talked about that with GA. It's the thing that assigns the patient responsibility for the remit notice. GZ says, don't change the remit notice. Leave it as a contractual obligation and we will write it off. GA says change the patient notice and allow us to charge the patient for it. So it's the opposite of the GA, and it's simply because you didn't give it out. Okay? Now, sometimes we do get appeals filed for a GZ because you didn't know or whatever the situation is. That's fine. Go ahead and do that if you want to. But a lot of those appeals actually come from the patient saying, we think this is, we believe this is, you build it as this is, and that would be the GA, GY, GX, and GZ, any of those. The patient should file an appeal to us, even if you don't have appeal rights, they do. So while these may help us understand what happened and what information was given to the patient, and you may be like, I built it according to what I should have done. If the patient calls you and says, well, you can't bill this way, your response should be, we build it according to our information. What you need to do is to file an appeal and follow the directions on the appeal. So I know that sounds very contrite to say that, or, oh, they're not really helping the patient. Here's the thing. The patient may call 1-800-Medicare and they're going to explain it however they want. You're not on that call. We're not on that call. We don't know what they're telling them. That's why you need to build the appropriate modifier and then let the patient do the appeal should they need to. If we need additional documentation from you because the patient filed an appeal, we will send an additional documentation request or an ADR for that information. But again, make sure your modifier is built correctly based on the information that you have. Okay. So hopefully I answered that question as well. The next section is actually going to look at the ABN, the Advanced Beneficiary Notice of Non-Coverage. This is the section that was updated. Before we do this, I do want to ask Ashley if we have any questions in the chat that I haven't addressed. Hopefully that will get these questions addressed before we get too far into just using the form. Otherwise, I can take them at the end too, so we can take that there. Ashley, anything?
Hi, Tom. We just have one question in the chat that relates to frequency. And this one asks, for vitamin D and lipid panels, there is no official frequency limit, but we're receiving denials. Can we provide an ABN?
Sure. And again, the answer is sure. Why? Because you're trying to cover yourself. You're not doing it across the board. You're not doing it for every single service. That's called a blanket ABN. Don't do that. Now, in this case, you're simply saying, hey, for vitamin D and lipid panels, we don't know what the frequency limit is. Now, again, if you have something where you're saying, hey, by the way, this is what's happening, and this is what we have, happened in the past, and I'll use history of claims, looks relatively like that, you can provide an ABN because you have a history. You have some support for it. So you could use it for that purpose. Um, next question.
We had a couple more questions come in. The next one is, what is the difference between not covered and not medically necessary as far as ambulance services is concerned, especially for emergent ambulance services?
Okay. There is a very limited difference. Well, it's actually the cut and dry difference of the legal benefit. For ambulance services, the legal benefit is in section 1861S7, and it states that there are two parts to this. One, it has to be a transport. So if you don't load this patient and physically transport them somewhere else, you do not have a payable service. That is not covered. Okay. On the other part of it, it says the service has to be contraindicated, which means that when you're an emergency medical technician, and it doesn't matter if it's a basic, intermediate, or paramedic, I'm going to use EMT just in general terminology here. When your emergency medical technician does an assessment and documents it, it has to be something that is requiring their medical skills or their medical monitoring. There has to be a reason for it. If it doesn't meet that, then it is considered not medically necessary, which is contraindicated, meaning they could go by a different safe means. That is also not covered based in section 1861 S7. Not medically necessary for ambulance is when a ambulance transport must be complete. It is the only safe method of transport. However, it is completed at a higher level of transport. The biggest one that I've ever heard of, and the only time I've ever heard this used with an ABN, is that a doctor orders an air transport, but the EMT assessment shows that it would have been safer to go by ground. It would have been less time. The patient's condition doesn't justify air. It's not that we're not saying they can safely go by a different means. What we're saying is the ambulance ground would be safe, so taking them by air is their responsibility, the difference. So hopefully I got all that stuff in there. So it's not about emergent or not emergent, okay? Let me say that. I'm going to go ahead and go on. Any other questions, and I want you to be aware of this, any other questions we will take at the end as well. I just want to get through the form and hopefully help answer all these, okay? Thanks, Ashley, for that, and let's get started with the form. The form and instructions are available on the CMS website. I'm going to show you this because I think it's really, really important, especially right now. And I'm also going to show you this processing manual because with the change, it becomes even more important, if that makes sense. So let's take a look at where to find those on the CMS website. First, it does require you to go to cms.gov, and that's right here. Now, some people say to me, can I search ABN? You bet. Can I search BNI or the Beneficiary Notice Initiative? Absolutely. Do whatever you want to do there. I'm going to take you through the step-by-step process in case you don't like to search. Okay, let's move on. What do? We pick one and we go from there. Please don't do that. What you want to do is look at these different categories. If you notice, I'm scrolling down and I'm looking at forms and notices. Advanced Beneficiary Notice of Non-Coverage is a form. So let's go here. Now, what section did I tell you this falls under? Medicare talks about this in the Beneficiary Notice Initiative, or BNI. So let's move to BNI on the right side. And then we get to read all about BNI. What's great is two things. First, here's a link. On the left navigation, it's the first link and you can select it. I want you to note the FFS, fee for service. Different, and I'm just going to scroll down a second here so you can see this. See how on the 1, 2, 3, 4, 5, 6, fifth and sixth denial, it also says MA. This is Medicare Advantage or Part C. Because this does not say MA, that means the form that we're talking about and these modifiers are not applicable for MA, not applicable for Medicare Part C. They are not a part of that. Okay, so that's what FFS stands for. I apologize, I tongue-tied myself. I do want to point out a little bit more information for you here. If we look down, we can find all these different notices. I want to point out the message on March 13th that tells us they finally completed the review, though it was looking like this would have expired at the beginning of the year. They completed it, now have updated it to March 31st, 2029, when the ABN will expire, which is the CMS R131, and that you have until May 12th to use any of your old ones. May 12th. So that's why I'm going to kind of tuck a little bit back and forth, but I really did want you guys to get the new one. Scrolling down from there, scrolling down, scrolling down, scrolling down, you'll come to a chart. Super easy way to get to this. Here's the form. Scroll across. Here is the actual form itself, and here's the form instructions, which is a PDF. There you go. This is what we're going to go through. If you want to download the form, I do recommend. Nope, there it comes. I'm going to recommend this. It just didn't want to open for me. You can go ahead and save it, and we're good with that. By saving it, it's going to give you some different options for the form, and it really is, oops, don't know why I did that, but what it's going to do for you is really have you open up some different options. And the reason for that is, do you want English? Do you want Spanish? You have to use the proper form to help the patient understand. You've probably heard me say that a little bit in the past if you've attended any of my webinars. So, oop, Ashley, can you see my my file box?
Yes, I can see the file box.
Perfect. So this is just what the file box looks like, no big deal. The slide prints that I have for you are from this version right here, not from the large print version. Also, it's not from the Spanish version. I'm going to do the English version. So hopefully that helps you a little bit. But this is where I got it from. And then again, the instructions is a PDF and you just select that and it opens up and you can read through the instructions. Okay. There is a little bit more information on this. What I'm going to do is actually, we're going to change this one and we're going to go to cms.gov here too. Now this was Medicare, but we're going to go to CMS, cms.gov. We're going to go to Medicare under regulations and guidance into the manual system. And the reason that this is important is when you're in the manual system, we're going to go to the internet only manuals. And then once the left navigation is selected, you'll see the body change and you get to scroll through and you see all kinds of publication numbers. We're looking for the Medicare Claims Processing Manual, which is publication 100-04. Select that. I want you to scroll down. You're going to read about general billing requirements and lots of other things, inpatient services, all of those things. These are instructions to us as your claims processor as to how we have to work with these claims. But along with that, and look away if you don't like my scrolling, I'm going to apologize for that. It takes me a minute to get down to this part because it's chapter 30. Chapter 30 is the financial liabilities protection. It works with the Medicare Beneficiary Initiative, so chapter 30. When we open chapter 30, we can read the different sections on what we're looking for and which one we want. If you don't want to read through all these different sections, you're like, I don't know. And to find out that you want section 50, you can also use the edit, find, or the control F feature. Okay, so that's it. That's what we got there. And then you go through and you find out, okay, here's our mandatory, here's our optional use, and that's where I came up with the terms mandatory and optional, and you'll see those right here. Issuance, triggering, all of those different stuff. If you want to learn about standards, you got that too. Now that's also going to be in a couple months. We're going to talk again about the ABN because we do have changes and we do want to focus on that. And this one, we're really focusing on the modifiers. So when you go to look at the beneficiary notice initiative, this is the big dog one, right? What I want you to do again is go to Medicare. And what I want you to do is scroll down on the list and I want you to find forms, forms and notices. Then come to the right side, look for the third item, beneficiary notice initiative. Awesome. And then scroll down again and you're going to come to a chart. So that's what we're looking at. Let's go ahead and move through the form a little bit. So we located it. We got some basic information. I wanted you guys to have as much as I could get for you. Okay. The top of the form, and I actually, why don't I just go ahead and open up the form instead, and we'll go ahead and grab this. So give me a second while this downloads. I already have the download open, so I think this will be easy enough. There it is. So we're going to go ahead. I'll just, for lack of a better one, I'll open up the English version. So I'm going to have you guys look at the top area on the slide. What I'm going to do is just, I'm going to use the actual form to show it to you. So hopefully that makes sense. Ashley, do you want to verify that I am actually showing the form itself?
Yes, I can see the form.
Perfect. When we talk about the top area, this is what we're talking about. Now, CMS used to have an A and a B and a C up here, and they removed those. So that's one of the changes. They also moved the notifier information to the right side from the left side and the patient information from the left to the right. Not huge changes, but definitely something I want you to be aware of. You do need the patient's name. According to CMS instructions, this should be what the patient Medicare file says. However, we would accept something the patient will recognize. So for instance, my legal name, my Medicare name, or my Social Security name is Thomas. However, if you presented me with Tom, I'm going to recognize that. So is anyone else representing me. This identification number, I do want you to see the word optional. You can remove this word optional. It doesn't have to be there. But this identification number is something from your records and how you identify the patient. It's not Medicare's number. Okay. One thing I want you to keep in mind is if within your record you use a Medicare number to identify the patient, do not fill this out. Just leave it blank. You can't remove it, but you can leave it blank. And on this side, the notifier name, address, and phone number. Again, you can take off the word of notifier name, address, and phone number and just put who are you, what's your street address that the patient would know, and what is your phone number. If they have a TTY situation, how would they get a hold of you, any of that type of thing. Next, you'll see this paragraph. Now, on the old form, there used to be what was called D period with a line, and you used to have to insert item, test, service, all of these. CMS just standardized the verbiage and put it in there. That does make a change. It makes it a little bit easier for y'all to fill out. We then moved down, and we used to, on the old form, have D period with this, which is the chart description, E period, which is the reason for Medicare not paying, and F period, which is the estimate cost. So when I want you to go back and think about the slide that we talked about using this with a GY, never covered service. Stop. You do not need to do the rest of this form. You do need to make sure that the patient knows who they are, and yep, if they have an identification number, yeah, who you are, and then these three. That's it. Done. Do you have to do this? No. So you don't even have to give this form. That's a GY. If you do give this form, can you remember which modifier you should be reporting? GX. Okay? But GX indicates you just did this top part up here. Right? So that's where we're kind of talking about some of the different items and services we wanted you to be aware of. A couple people did ask me about this items, test, and services and what is Medicare looking for. Don't use a procedure code. Use a term that the patient would recognize. So it could be a lab panel or lab services for something, and that something is what it's for. It may incorporate more than one lab, in which case you'd give the total highest estimate. If it happens to fall in below that, we're good. Why won't Medicare pay for this? Maybe it's a frequency limit. This is outside the Medicare frequency limits. Okay. Maybe today this isn't covered for your condition, not medically necessary. Maybe this is never covered. It's not a Medicare benefit, right? We'd want to tell them that too. Lots of questions on this final one, and that's the estimate cost. This one always throws me off a little bit too, but basically CMS did remove some of the instructions for this. And I want to make that clear. What they've said is, hey, go high versus low. Well, that makes sense. Tell the patient it might cost them a bit more. My example of that is a lab panel. Go with the full panel amount versus an individual test amount. That will make sense to the patient. You may get charged $300, but the reality is you're only going to get charged $50 because you only did one test on the panel. That's fine. Okay, high versus low. For those of you that are familiar with the $100 or 25% of the actual cost, that has been removed. WPS does offer you one piece of advice. When you do your estimate, start with your cost as if you were charging a patient who does not have any form of insurance, a private pay patient. Start there with your estimated cost. Then look at it and say, okay, I think it's going to be this, but the reality is I could add these three things on based on this result, then move it up. Hopefully that makes sense. If you need more, let me know in the chat. All right, so now we've got this for the GX or the GY. We've completed the entire form. We give it to the patient. We're good. I'm sorry, this should be GX. GY, you wouldn't even look at this. Let's continue on with the GA portion. Okay? Then the patient gets to pick an option. Which one do they want? This is where you bill GA. This is don't even bill Medicare. However, the patient still wants the service and they're willing to pay for it. And the last option says, I don't want the service. You're considering it not medically necessary. I don't need it. Okay. The next is completely optional. The optional portion down here is something you can put additional information in to help the patient. It's something you can document almost anything within that. Like, hey, they didn't want to sign, so here's what I have to do. The patient decided to pick option 2, but now came back 10 days later and said, no, I got a bill, but I don't want to pay it, so I want you to pick option 1. You would document that change right here. So it's just a lot of additional information. Almost anything can go in that box. Last, the patient's signature with the date. If someone is signing on the patient's behalf, you need to indicate the signature with the word rep, REP, or representative, full word, doesn't matter either one, just something like that. And that just tells us that the patient didn't actually sign it, but someone did on their behalf. So hopefully that does make sense. Okay. Um, so when we look at this and we say this is presented electronically, CMS says that's great, no problem. And someone has to go ahead and select an option, and you're saying, I select the option, but I still have the patient's signature somewhere. Can this be considered invalid? The answer is yes, but it all depends on how it documents. Yes, they still have to have some form of a signature. It could be a check yes box to accept, and then it puts an electronic signature on it. That's great, right? That's an electronic form too, and it's not that CMS prohibits this in an electronic form. But I did want to make that clear because with the updates, you still have to make sure you update that. One other item that's within the CMS instructions is what happens when an ABN is done for more than one provider. A couple of examples fall into the lab service, or it has a surgery, an anesthesiologist, a co-surgeon, all done at an ambulatory surgery center. So we've got four different bills. Do I have to issue four different ABNs? And the answer is no. What you do is up here in this notifier name, the person issuing it, I'm giving it to you today, right? I'm the provider. You then, in this notes section or additional information, indicate how to contact. This is also affects so and so, so and so, whatever the patient's going to see so they know who that is and how to contact them. You're going to basically give them these three pieces of information for each provider affected. Hopefully that makes sense to everybody. This is who provided it. This is the other providers that are affected. So that's what I have on the form. Again, I'm sorry I gave you guys a lot of information, hopefully not too much. When you look at these different slides, hopefully we're giving you what you need for each one. And we do want to talk a little bit about that. I'm going to move on to the question and answer section, and we're going to start with pre-submitted. I will flip back to the questions in the chat in just a few moments. Okay. Oops, sorry, I went too far. Um, Questions and answers. Does Medicare require a code to indicate the date the ABN was provided? What they're talking about is an occurrence code, and this is for a biller who bills on a UB04 or 837I. For those of you that bill on the 1500 and 837P, you're like, what's an occurrence code? I don't even know what that is. That's because you don't put it on your claim. If you do bill on a UB04 or 837I, the answer is yes, we do. If you don't put 32 and the date the ABN was issued, you should not be billing GA and GX. If you are billing either modifier GA or GX, I must have occurrence code 32 or we're gonna return it back to you to say you didn't complete the claim. It's gonna be a return to provider indicator. Next, what modifier is used on a claim for a test that is not covered for any diagnosis per an MCD? Remember, not covered per diagnosis can be a GA. Okay, it's not covered for this diagnosis. Now, if it's covered for a different diagnosis, that's where we would look at it. So today's test is not covered. This is also given when it's a not proven test. Doesn't work for whatever that is today. It does mean that tomorrow it could be covered if a different patient came in and they have a different diagnosis and that test then covers in an NCD. Perfect, right? Today, your diagnosis doesn't make it payable. And what you want to write on the ABN in that section is Medicare doesn't pay for this test for your condition. That's what we're telling them. The next question kind of goes with that, and the actual question was not about a test, but it was about contraception, and it says Medicare doesn't ever cover contraception. Yes, this is an excluded benefit. Never covered, not covered. We did provide an ABN. What do we do? Well, how do you indicate that you provided an ABN for a never, ever covered service? Excluded from the law. You append modifier, GX. Now, if you didn't provide an ABN, that's cool. Just append GY. So take your pick on one of those two. Okay. This will then assign it, and it should assign patient liability. Someone asked, apparently their state's Medicaid covers it. This will append patient liability and allow you to submit to Medicaid as well. That's the next set of portion of that question. Okay. GY. Does GY get used with non-covered services? Yep, we've talked about that a lot. But the catch with GY is that it's used when you do not provide the ABN. GX means non-covered, but I did give the ABN and I completed just those top sections. Oh, this is one we just answered. I'll reiterate just really briefly. So how does Medicare work for modifiers work for ambulance transports and specifically the assigned claims? So for ambulance transports, because you do not have a diagnosis, and because their payable benefit is in section 1861S7, which when I went up to the internet only manual, if you looked up optional use, anything in section 1861 does not require. So again, you would use GY or GX, did you give an ABN or did you not, to say it is not a payable service because the EMT did an assessment and it's not medically necessary, which means it is contraindicated and they could safely go by a different means. Or you use GY or GX because you didn't transport them and you have to transport them to meet that definition to start with. On the other hand, you would use GA or GZ when you say, oh man, they could have gone by a different, they could not go by the transport must be done completed by an ambulance. The only safe way. However, the ambulance that was chosen is higher than the benefit category needed. For instance, they went by air, but ground would suffice. So hopefully I have all of that information. If not, you might need to put a little bit more. Someone very specifically asked if there's a list of statutorily excluded services by HCPCS or CPT. Not necessarily a complete list. Again, some of those are available. If it's a physician service, you could look at the physician fee schedule, look at the indicator, the Medicare indicator on whether it's covered or not, on whether it's active or not. So variety of different things. A couple of things to keep in mind with that is if it's got an X, it's not that it's not covered ever. It may be that it's actually on a different fee schedule. Okay. Also, in the Medicare policy manual, our benefit manual, sorry, on cms.gov, remember we went out to regulations. I need to back up just a little bit more here. You're going to go into 100.02, the Medicare benefit policy manual. Once you're in 100.02, you're going to scroll down. What you're looking for is a chapter called excluded from coverage. The word exclusion means never, ever, ever covered, and it will actually walk you through the different exclusions. Again, it doesn't necessarily talk about things like procedure codes, but it does give you a lot of situations and scenarios. So I'm not entirely sure there's ever going to be a list of just these are the excluded services. Let's see. Next question. If a patient has mycotic nails, but not one of the systematic G codes, what do we do? If the diagnosis doesn't meet that, again, which could be one of the G codes, and you're looking at the foot care information within the manual, then you would want to give an ABN and use the appropriate correct modifier. What is the appropriate correct modifier? GA. If you don't give the ABN, you would use the GX. Are modifiers required if a service will never be covered? No, they're not required. Remember that if not required, this will not change the processing, but it will have to go through the entire edit system before it kicks out. So the exception to that is an ambulance transport because your code still is the same as if it were covered, and an EMT is not allowed to use a diagnosis to tell us it's not covered. Medicare doesn't do that, even though it's on the claim, which is a HIPAA requirement or a claim requirement, then you do have to use it. We were asked when to use the GX. Again, use the GX when you should, or when you did give an ABN, but you didn't have to. You could use the GY. It's just a never covered item. What modifier for self-administered drugs when we are writing them off and billing the patient? Well, if it's a self-administered drug, it's excluded from services. What I need you to do is to look at whether or not that could ever be covered under Medicare. And the answer is on a self-administered drug, no. So what modifier would you use if it's excluded from services? GY and GX. Okay. Understanding the revocation dates apply. I wasn't really sure what that question even meant because the ABN does not have a revocation date. So I don't really know what you're talking about there. Uh, you need to add more into the chat. Best use of ambulatory surgery center in these four modifiers. There is no best use. The way to use it is it's situational, just like anybody else. Somebody was asking about procedure code 99397. So 99397 is considered used for a routine medical reevaluation and management of an established patient. It is an annual physical, which is a non-covered, never covered service. Therefore, no ABN is required. If you give it, use GX, otherwise use GY. Next question, which one gets listed in the first position? All I can tell you is look at our website, look to the modifiers information. If it's an informational modifier, everything else goes before it. That would be these four modifiers. Well, they're all informational. I also want to tell you, don't be appending two of these modifiers in the same claim. Someone did that, and I don't really know what's going to happen. Clarifying the GW modifier use. I'm not really sure what you want to do with GW. GW is not anything to do with the ABN or even anything on here. Please attend that one in an hour. All right, I'm going to take a few chat questions. So Ashley, go ahead with those if you have anything for me.
All right. We did get several more chat questions. The first one is, and you kind of touched on this, but this one is, are ABNs to be signed by Medicare C? I'm assuming they mean Part C patients.
No, fee for service only, Part A and B, traditional Medicare. Remember, outpatient benefits though. So hopefully that answers that question. Next.
All right, next we have, it says, this is a frequency question. What if we, as the clinic, do not know if patient already received, oh, this is a DME question. Let me get to the next one. So if it is not medically necessary and contraindicated, do we use the GY modifier?
Yes. Yep. If you don't give the ABN GY, if you do give the ABN GX, I just want to mention that we don't process durable medical equipment claims. That's why Ashley skipped that question. I can't give you any advice on durable medical equipment. You have to go to that Medicare administrative contractor and ask them questions. All right, Ashley, next question.
All right. Next one is, if we want something to go to provider liability, like self-admin drugs, what modifier are we using? And does the charge have to move to non-covered column on the claim?
So self-administered drugs, yes, non-covered on the claim. And you can, again, use a modifier GY or GX. That's up to you. The problem with that is you don't have to, right? You're already putting it in a non-covered column. And as I said before, those are purely informational modifiers. So if you don't put it on there, it's still going to go that way. I don't know what else advice to give you on that one, so hopefully that makes sense. But next question.
All right. If we bill for surgeon, ASC, and anesthesia for a procedure, do we have to have 3 ABNs?
Oh, please don't do that. I mean, you can. I want to make it clear. CMS says yes, each billing entity can issue an ABN and each one can fill out that top part. But for the patient and to lessen the confusion, whoever issues the ABN, include the other two in that narrative section in that open box. Way easier for the patient to understand. So that's why my advice to you is please don't do that. Make it easy on the patient to understand. So next.
All right. Next we have, if our electronic ABN form has check boxes instead of circles, does that invalidate the ABN?
No, not at all. not even a little bit.
All right. We have a couple more. Do we have time to get a few
Yeah,
more?
keep going. I want to get them all out there, and then we'll then we
All
might
right.
get a minute or two over just so everyone's aware. But you're welcome to drop off if you need to.
All righty. The next one is, should the rep sign their name and indicate rep, they should not sign the patient's name, correct?
Yes, their name. Who are they? We need to know who the rep is and why it's indicating rep, not the patient. That's a forgery signature, and we don't accept that. If that happens and we see that, it will invalidate your ABN. Next.
All right. We have, do we use GY with GX or would we use one only?
You either use GY or GX, never both, because either you gave an ABN or you did not. So,
All
next
right.
question.
The last one we have as of now is, I want to make sure I understand the ABN. Oh, and this is another DME question, Tom. I apologize. So
Oh,
I think
yeah.
that's it.
All right. So again, DME contractor, DME Mac, they'll get you the answers. I do want to move on, and we'll get done here for y'all. Thanks for the questions. They were awesome, and I really appreciate that. Oops. If you do happen to need to refund us money, and this can happen, if you misappropriate something, or the patient doesn't appeal and suddenly we come back and say something different, I just want to remind everyone that you can do the refund. You can do it on our portal. That is our preferred method. You can request a refund on our portal. So the request is the overpayment claim adjustment or LCA feature, and the refund actually comes back to us in a separate feature from financial where you can actually issue us an electronic payment. The other hand, there is a paper form you can use. Go ahead and feel free to do that paper form. Please make sure you are completing the top sections. I will ask you guys that if you want to see any of those pieces of information, throw it in the chat. I'll take a look at it in just a moment, but I do want to finish up for those that are ready to go. Some additional resources. I've shown you all of these different things, so please take time to look at those. The two on the bottom are actually what I went through, with actually the information. So survey. We're going to ask that you take a survey. What we're looking for is how we did. I'm going to have Ashley put the survey in the link. I'm going to send you this survey in the email, which is going to come out in just like a minute or two. And also on that survey, I'm going to give you a pop-up box. This is how bad I want your feedback. It's only 4 questions, maybe 5 questions. Please take the opportunity to do that. If you elect to give us more, you can do that. The pop-up box actually looks like the first picture on the upper right side. The survey is also something you can take from the Encore. That's the bottom picture on this slide that says online survey with the little finger. That's what it is. So we'll give you that opportunity as well, but just be honest with your feedback. Help us understand what happened. Thanks for attending. We really do appreciate it. If you have any follow-up questions for the next 7 days, remember that's 7, we'll take those questions. What'll happen is I'll either email you as a group or I'll email you individually. It really just depends on the question that's sent in. And what you want to do is email us at wps.gha.education@wpsic.com and put modifiers webinar, something about, modifiers, maybe ABN, GA, GY, something like that, just to indicate who it should come to, because that's me, and we'll know that. And then we'll get back to you as soon as we can. All right. If you didn't catch me reading off the email, please feel free to look in the chat. Ashley did place it there. All right. Thanks, everybody. I would like to thank you for attending. Thanks for the great questions. It makes it a lot easier on us. Remember that we'll post the encore of this event probably within the next couple of weeks, so watch for that. It will be available in our YouTube channel well, not much earlier, but before that, and then we'll post it onto our website. On behalf of myself and Ashley and all of Provider Outreach Education, really want to thank you for attending and participating. I do look forward to your survey comments and hope that you'll join us for future events. Go ahead and disconnect. Have a great day, everyone.